So it's a pretty rare entities, at least that are around the knee joint. So what we do is, what I like to do with all of you is to share some of my experiences in dealing with these patients in surgical oncology. So we know that we deal with different types of tumors around the knee joint. So we did see in the last presentation some bone tumors. So primarily we deal with bone tumors such as the osteosarcoma, Ewing sarcoma, and the very young ones. But then again, in the older ones, we deal, of course, with metastatic disease, just like this renal cell carcinoma on the distal femur. We deal with lymphoma and also with some soft tissue sarcoma, which are pretty rare, but some of these encasing the total bone, and there's no chance to get a good surgical or oncology margins while not resecting part of the bone, and just like in this case, the distal femur, and then you have to replace it using some tumor endoprosthesis. Then, of course, there are even more rare tumors, just like this benign bone tumor, the giant cell tumor, with a total destruction of the distal part of the femur. So there's no chance for curettage and filling or using denosumab in this case. There you need to do something about the destructed bone, and there's an indication also for using tumor endoprosthesis. So the conditions we face in tumor surgery and surgical oncology are totally different in comparison to primary arthroplasty. So we deal with very, very large bone defects. So in average, it's around about 18 centimeters for the proximal tibia and also for the distal femur. If you look into literature, and this is what our own data suggests. So sometimes it's more, but and sometimes it's less, but in average it's around about 18 centimeters, which is a huge distance to reconstruct. Then, of course, we have the loss of functional musculature. So what we need is to provide a good function for the patient after surgery is enough musculature. And if you look at these papers, these slides there, these images, you're going to see that there sometimes we deal with tumors with a huge extension into the soft tissues. And there you can imagine, if you want to get good margins, you need to sacrifice a lot of the surrounding musculature to get clear margins in terms of oncological safe margins. We have absolutely, and this is absolutely different to normal arthroplasty, we deal mostly with oncological patients. So they receive additional radiotherapy locally, for example, in Ewing sarcomas, where we do it most oftenly. And of course, you deal with patients that are treated with systemic chemotherapy. And these are both factors which influence our results in terms of function but also in complications negatively, and which are the most important factors in terms of wound healing delays, wound healing complications, and infections. So other preconditions are we deal with patients of every age group. So we start with a very young one, so around about 5 years of age. I think this is a good age to think about using endoprosthetic replacements. And also we deal with very old ones, which are sick, which have comorbidities, and they are not doing that good as in primary arthroplasty, at least most of them. We have in the very young ones, very small anatomy, just like in this case. You're going to see this is just round about a layer of soft tissues of 1.3 centimeters around the bone, around the tumor. You can imagine if you use normal conventional implants with these huge volumes, then it's very difficult to reconstruct the bone defect, but also to cover the implant, which is decisive for a good function and reducing the complication rates. And they need to last long. So if you treat a patient with the age of 6, 10, 12, even 20 years, around about 70 to 80% survive their disease. And then the implant needs to last centuries or at least decades. And this is something that we have to keep in mind if we deal with these patients. So just some examples for a distal femur replacement. We already saw this image. It's a late solitary metastasis of a renal cell carcinoma in a 75-year-old patient. So in these cases, we tend to do a wide resection because there are several studies showing that they might profit in terms of overall survival if you do a resection in the late metastasis in this disease. So after biopsy, and which confirmed the histology, we did a wide resection and put in this tumor endoprosthesis. And as you can see, I tend to use, in around about 85 to 90%, I'm going to use cementless stem fixation, because I think this is more easy. It saves some time during surgery, but also in case of revision, it's more easy to handle if there is a non-cemented stem in comparison to a cemented stem. And the results I'm going to show you later are pretty good also. So if you, second case, it's a Ewing sarcoma, which is becoming a little bit more difficult. This is a pathological fracture. You can see this MRI there with a huge soft tissue expansion. It's contaminated hematoma, and we need to do something about that. So this patient received neoadjuvant treatment. We put him in a plaster, and good luck, had a good response. So there was a huge tumor shrinking during neoadjuvant chemotherapy, and so some consolidation of the bone. He was doing fine, so we didn't do any fixation. We just put him in a plaster, and he did so well during the first courses of chemotherapy. And this was something we decided then to try to salvage his leg. We need to sacrifice the knee joint because there was a huge tumor expansion distally, but we were able to save the hip joint, and the patient was doing fine. But obviously, these patients need neoadjuvant, or at least they need chemotherapy, but they also need local radiotherapy to control the tumor and at least the local recurrence. But this worsens, of course, our results. However, results on distal femur are not too bad. So for us Germans, we still have some good winters and have snow in the winter time, despite global warming. And so the patients need to do some sports, and in winter times I like to do some skiing. Obviously, it's not that all patients do that good like this patient, but I always like to present this video because some of them are doing quite good. So come to the proximal part of the tibia, to the proximal tibia tumors. So this is a bit more difficult. So this distal femur replacement, mostly you have some good soft tissue coverage. In the proximal part of the tibia, you just can feel your chin bone. There's nothing on top of it, just skin and some subcutaneous fat tissue. So it's more easy to cover these implants. And this is an example of a 13-year-old girl with a telangiectatic osteosarcoma. She had a contraction of the knee joint, so I didn't get a better imaging. However, she received neoadjuvant treatment. She responded well to treatment, and then we decided to resect the bone and reconstruct it with this tumor endoprosthesis, and again with a non-cemented technique. So what makes it a bit more difficult is that you need to cover the implant, particularly ventrally, because otherwise you won't get an infection in close to 100% of these patients. We tend to use the gastroflap in these cases also. We just saw it with Dr. Freitas presented some of his cases. It's very much the same technique. So I can go through this a little bit faster. So you have to reattach the extensor mechanism and the patellar ligament on top of the implant. And we use either one Trivira tube, or last couple of years, I tend to use some resorbable mesh, which works quite nicely also. And then you get a good biomechanical link between the implant and the extensor mechanism to get some active extension left. And then you just cover the implant with the gastroflap, you close the wound, and then you close the skin. And this is just one example of a young woman. She's doing quite fine, and most of the results present, at least my experience is that most of the patients get some good functional results and an active range of extension in the knee joint with not that much deficiencies. So another thing is where it's getting even more complicated is intra-articular tumors. So some of these, and these are very rare cases, just around about, I would say 1 to 5% of these distal femur tumors which have an involvement of the knee joint. And when there is obviously tumor within the knee joint capsule, you need to make the decision whether you do an amputation in these cases, or you try to get the tumor out, including the knee joint, to keep it closed during the surgery, and then do a reconstruction of the knee joint. This is a technique we did in some cases in the past. So you need to have at least more than half in the extensor mechanism. You even lose more musculature than a normal distal femur replacement. You leave the joint closed during surgery, and then you halve the patellar tendon. And then in most of the cases, you're able to remove the distal part of the femur. You cut somewhere in the tibia and remove the proximal part of the fibula and leave the joint closed. So you have a good margin for the tumor resection. However, this works out as a surgical technique, not too bad. Although we just looked at some of our patients that we treated some years ago. We published this paper some years ago, but you're going to see that the survival rate of these implants is not that perfect. So you have, after 5 years' time, less than 40% implant survival. However, we were able to keep the leg in most of the patients. But if you look at the complications, we faced a lot of complications in these patients, more than in a normal distal femur replacement. So a periprosthetic infection in 22 of these patients, which was around about more than 40%. And this was an awful result. The function results are not too bad, but to be honest, when I need to do this decision, I always talk to the patient, maybe it's better to do an amputation, because in the long run, the function results are better in these patients. However, if they refuse an amputation, then you can try it. It's not too bad from a functional point of view, but it's not perfect anyway. So another point is what I just mentioned before is we deal with infants, we deal with a growing skeleton. And if you have distal femur or proximal tibial tumor, in most of the cases, you need to sacrifice at least one physis. And this is something where we have to deal with it, because if you treat a patient with the age of 5 or 6 years, then he has around about 10 years of rest growth. And you have a growth of around about 2 centimeters around the knee joint every year. So this makes up to 20% of leg length discrepancy. And this is not easy to handle if you don't do anything about, just like doing using, for example, expandable implants, or using custom-made implants, or a combination of both, to deal with a small anatomy in the very young ones and to try to lengthen the leg. This is something, as I told before, I would just recommend for patients below the age of 5, with the age of 5 or older, and below the age of 5, for example, for young 1-year-old boy, I wouldn't go for an endoprosthetic replacement, because you would face too many revision surgeries during the course of skeletal maturity. So in these patients, I tend to do some, for example, this rotation plasty, like we did in this very young one, because I don't really believe that if tumor endoprosthesis in these patients is really helpful in the long run. Okay, so they're not doing too bad, but if the patient is older, or the patients are older, then I like to use these non-invasive distal femur replacements, growing prosthesis. They are doing at least a good job. You can lengthen the implant depending on the reconstruction length, somehow between 5 and 7 centimeters in one step, at least in 1 millimeter steps per day. And as you can see in this X-ray, we lengthen the implant around about 7 centimeters in this patient, and then you can level out the leg length and balance the leg length in these patients. And this works quite nicely. Another idea or another technique is using these bioexpandable implants. So there is at least it's a distal femur tumor endoprosthesis, which is connected to a growing nail, and then you start some lengthening over the nail procedure. The advantage is you have a good, you make the ratio between implant and bone is getting better by extending the bone by this lengthening procedure. But the problem in these is sometimes that you can't stop the lengthening procedure. So you have to lengthen at least the full length of the implant or the nail, because you can't stop it during the lengthening procedure, because then you get a consolidation of the bone, and then you need to get back in the second surgery and make a new osteotomy if you stop it in between. But it works out nicely. So we did a couple of these patients and they are not doing that badly. So I think expandable endoprostheses are not longer an experimental technique or surgery. So there's a nice multi-center study published some recently with around about 107 patients. They used the Stanmore implant, non-invasive expandable distal femur in this case, and they had I think acceptable rates of complications. They faced 7 infections, but they had an implant survival of 66% after 5 years and 48 after 10 years. So this was not too bad, and they were able to lengthen most of the implants without that much technical complications. So, but now let's come to the complications we face using endoprosthesis in the distal part around the knee joint in tumor patients. There was published in 2018 this paper, Chinese paper, that summarized some of the results with patients, with oncological patients treated with distal femur and proximal tibial endoprosthetic replacements. And what you can see is that the overall survival of these implants is not too bad. You can't compare these with primary arthroplasty, of course. As I told you, these are oncological patients, and this is a little bit more difficult. But however, the 5-year survival rate of the implants is in average around about 75%, which is not too bad, I would say. The MSDS score, which is the kind of functional score, was not too bad. So 100% is perfect, and it's around about 80–85% in average, which is good also. And then you look at the rate or the cause of complication, and the main problem is infection, as Dr. Freitas stated in his presentation. It's the most serious complication, but we also face some aseptic loosenings of the stems of the implants, and of course some mechanical failures. And this is most often in the knee joint, aware of the bushing. And this is something you can't really avoid in the long run just by improving the implants. And then there's a second study I'd just like to present you of a very long follow-up patients. So this is a study from the Birmingham group. They had patients with minimum of 25 years after primary surgery. It's not just the tumors around the knee joint, they included the humerus and some more. But however, you're going to see 200 patients were eligible after 25 years from 564. So you nearly lose 60% of the patients in the long run because they die because of the disease or because of other causes. But you're going to see, and this is what I wanted to point out, is they had 610 further operations. This was just around 2.7 operation per patient in the 25 years as revision procedures. And there you're going to see some of the patients had even around about 10 revision procedures in their clinical course. So the risk of amputation, in particular for the lower extremity, because there was no amputation in the upper extremity, was about 16% at 30 years. But so you're going to see most of the extremities can be salvaged. The proximal tibia had the highest risk of infection, which was around about 43%, which is a lot. And the risk of infection was around about 2.7% for every revision procedure, which is not that low. And they stated out also that the risk for infection for every patient is around about 1% per year. And this is something we have to keep in mind. The most common reason, even in this, and also in this paper, was aseptic loosening, was rebushing of the knee joint mechanism, and it was infection. However, functional result was good, as I pointed out on the slides before, and the survival of the leg was, or extremity, was not too bad also. So around about 80%, 85% after more than 25 years. So what was the main problem in this paper was aseptic loosening. This was the main cause for revision. And there's always the question what to do. How should we fix the implants into the bone? I also told you before, I like to do some uncemented stem fixation. I think if you get a good press fit, then you get very, very few problems with loosening. In the cemented ones, it's always a question, how long do they last? There are several papers presenting some good rates on cemented stems. This is just a study from the colleagues from the Netherlands. They showed that using proximal tibial and distal femur endoprosthesis, the patients with a cemented stem did far better in terms of not facing the complication of aseptic loosening, and the cemented ones were not that good as the cementless fixation. So this is something I would say I don't think it's too bad. So it's my impression also. But of course, there are some changes in the endoprosthetic designs over the last couple of years. And even for the ones they like to use cemented stems, there are new implants with this hydroxyapatite collar, which seem to be beneficial in terms of reducing the risk of aseptic loosening. It's around about 7% in these studies. We just looked at our data, it's less than 5% using mostly the cementless stem. So I think this is not this big issue anymore in endoprosthetic replacements, but as we heard before, infection remains the most serious complication and is the most prominent and common reason for secondary amputation in dealing with these patients. We've heard if you have poo somewhere, an infection, you need to revise it, you make a good debridement, you need to put out all the hardware and all the metal and make a good two-stage revision. So we published these data and we did some research on the silver coating before in the last couple of years. We published this data in for patients with proximal tibial replacements. These were around about 100 patients, although just 56 patients were in the silver group, so in the treatment group. And what we did see is that we were able in these patients to reduce the risk of infection as the primary infection, but also in case of secondary infection rates, nearly half the rate of infection in these patients. And what was important is that we were able to reduce the rate of secondary amputation due to infection significantly, and nearly more than half in this rate. So I know these groups are not that large, and this is a problem dealing with tumor patients, is always that the numbers of these patients are pretty small. And then it's always a question how to do a proper study, how to do a good prospective study to really improve or to really show whether there's an effect on the silver coating in terms of prophylaxis or in terms of infection reduction. And this was a nice paper published this year. They looked at the quality of the papers dealing with this question. And if you're going to see, there are two of our papers, one and this is the other one, and green is good. So this is a good study. Red is not that good because there is a huge bias in the one or the other term. And you're going to see there's no study where just green spots. And this means because of the small number of patients, it's always difficult to make good conclusions. But however, what you can see is that most of these studies show some effect, at least a trend towards the effect of silver coating in terms of reducing infection rate. And this is something I really believe on, not just in terms of in patients with revision cases, but I really think that silver is able to reduce infection rates even in primary cases, and is effective to as a prophylaxis. So one last thing I just want to point out is a new trend and a new technological development in tumor endoprosthetic replacements, and this is the 3D printing technology. This is something which is very good because you can adapt with these implants very good to small anatomy. You can adapt to remnant bone stock by using these implants. This is CT based, and then this is a highly porous titanium structure. And this is something which heals perfectly into the bone. And this is something where we are able in the last 3-4 years to spare knee joints. So the best thing you can do is to keep the joint whenever possible and not replacing the joint. And this is something, just an example of one of my patients with a proximal femur replacement, but you can see this is just a stem with a length of just 2.5 centimeters. So this is very, very short. And some years ago, I wouldn't be able to preserve this knee joint. So I would have done the total femur in this case. But using this technology, we were able to have a good stability. So this guy has full weight bearing. We were able to preserve the physis, and we were able to preserve the knee joint, which is always good to have. Two other examples for these type of procedures. So this is a 15-year-old female with an adamantinoma, and you're going to see it's very close to the joint. You need some good margins. At least I like to have 2 centimeters to the tumor of safe margin within the bone. And we did a resection of this, and then we implanted this one. And again, some years ago, I wouldn't be able to preserve the knee joint because we didn't have these stems, or at least this type of stem, the small custom-made stem. But now she's doing good. So these are the post-op images. I did this surgery 3 months ago. I just saw her back in my ambulatory, and she's doing fine, has full weight bearing. So this is, I think, a good example of not sacrificing the bone or the joint if it's not necessary. Another, and my last example, is this 19-year-old female with an osteosarcoma. You're going to see it's a huge tumor within the soft tissues with extension within the femur. And again, I wasn't sure I wasn't sure how she responded to neoadjuvant chemotherapy. We did a resection. I just wanted to confirm that I have clear margins before I do a good reconstruction, because otherwise, if the margins were contaminated, we had to discuss about an amputation. But good luck, margins were free. She responded quite nicely to chemotherapy. And then we did this kind of reconstruction again, sparing or preserving the knee and the hip joint using these printed implants. And this is the second one is around about 8 months down the line. So she has full weight bearing, and she has very few complaints. So let me summarize. I think there are good overall rates of extremity survival dealing with patients or with tumors around the knee joint. The tibia is more complicated than it is the femur. Although we have to keep in mind that we have high rate of revision procedures in the long run, infection still remains the most serious complication. Growing implants are no longer experimental. I think they do a good job, and this new 3D printing technology might improve our results even in the future, and maybe we are going to do better than in the past. So thank you very much.